Hey everyone, welcome back to the channel. Before we dive in, if you find this useful, please hit subscribe and turn on notifications so you don't miss the rest of this pharmacology series. In this lecture, I'm going to walk you through a student-focused primer on anti-malarial drugs organized around drug classes and their mechanisms of action. Let me frame what's coming. Together we'll move from the malaria parasite life cycle and where the drugs act through each major class all the way to combination therapy and resistance. If you take one thing from me today, make it this: the single most useful mental model is matching a drug to the parasite stage it kills. Let me start with why these drugs matter. Worldwide, we're looking at 42 to 63 million cases and about 597,000 deaths every year, concentrated in young African children. 5 Plasmodium species infect humans, and I want you to remember that P. falciparum is the deadliest. I think of antimalarials as having 3 jobs: to treat blood stage disease, to prevent infection through chemoprophylaxis, and to block relapse and transmission. As I'll show you, those 3 goals are exactly why no single drug fits every situation. Now let me give you the big picture. I want you to imagine all the drugs sorted into 4 buckets. The quinoline-related agents, which are the largest family, the artemisinins, the antifolates, and the mitochondrial and antibacterial group. Notice with me that quinoline-related splits further into 4 aminoquinolines, amino alcohols, and 8 aminoquinolines. Think of this slide as a scaffold. Every individual drug I mentioned from here on, you can hang onto one of these hooks. Let me take you into the first class, the 4 aminoquinolines, and the prototype here is chloroquine. Here's how I want you to picture the mechanism. The drug concentrates in the acidic food vacuole and blocks the conversion of toxic free heme into inert haemozoin, and that build up of free heme kills the blood stage parasite. Note that it's active against asexual blood stages only. The key teaching point I'll leave you with is that widespread chloroquine resistance, driven by precursor mutations, ended its first-line role for falciparum, but partner drugs like amodiaquine and piperquine keep this class relevant inside ACTs. Next, I want to show you the amino alcohols, the quinoline methanols quinine, mefloquine, lumefantrine, and halofentrin. You'll notice a familiar theme. They interfere with heme detoxification and form toxic heme complexes. I always remind students that quinine is the oldest antimalarial we have, and it's still a backbone for severe malaria when artesunate isn't available. Let me flag the toxicities you'll get tested on: synchonism and hypoglycemia with quinine, neuropsychiatric effects with mefloquine, and QT prolongation across the whole group. Now let me get to a class I find genuinely special, the 8 aminoquinolines, primaquine and tafenoquine, because these deliver what we call the radical cure thereby activated into oxidative metabolites, uniquely kill the dormant liver hapnozoics and P-vapnozoites that peak lives of the ovule, preventing relapse, and they are also gametocytocidal, so they cut transmission. The critical safety point I never want you to forget, they cause hemolysis in G6PD deficiency, so you must screen before use. And notice that here the limiting factor is G6PD status, not resistance. Let me turn to the fastest acting agents. We have the artemisinins, which are the backbone of modern treatment. Here's the mechanism I want you to carry with you. The endoperoxide bridge is cleaved by iron and hemmed to generate carbon-centered free radicals that alkylate many parasite targets. They clear a broad range of stages, including gametocytes. Because their half-life is so short, I want to stress that they are always given in combination, never as monotherapy. And I have to flag the emerging partial resistance linked to KELCH13 mutations. Let me explain the logic of ACTs, because I find it elegant. We pair a fast, short-acting artemisinin, which gives that massive rapid kill, with a slow, long-acting partner that mops up the residual parasites and shields the artemisinin from resistance. The common amyloid combinations I want you to know: ALACE, DA, QAQ, PPQ, ASP, and ASMEQ. My take home for you is that combination is both more effective and a deliberate resistance management strategy. Now let me walk you through the antifolates. These target folate synthesis, which the parasite has to make de novo. Can't scavenge it the way we can. There are two enzymes I want you to remember: DHPS, blocked by sulfonamides and sulfones like sulfadoxine, and DHFR, blocked by pyrimethamine and progonal's metabolite cyclogonal. Hitting two sequential steps gives synergy, and that's the rationale behind fixed combinations like SP clinically. I'll point you to SP in intermittent preventive treatment in pregnancy and infancy. The caveat I want you to keep in mind is that DAFU-DAPS mutations confer resistance very readily. Let me show you a group that hits two organelles. Tovacone collapses the mitochondrial electron transport chain at cytochrome B6 complex III, which halts pyrimidine synthesis and propragonal potentiates it. Together, as you'll know them, they're malorone. Doxycycline and clindamycin block apicoplast protein synthesis, but I want you to notice they act slowly in what we call delayed death, so we use them with faster partners or for prophylaxis. My warning to you: atovaquone monotherapy selects cytochrome B mutations fast, so never use it alone. Let me give you this matrix as your synthesis and revision tool. I want you to read each class across the parasite stages: liver, blood, gametocytes, hypnozoites. Let me highlight the standouts for you. The 8 aminoquinolines are the only ones covering hypnozoites. The artemisinins act fastest on the blood stages and also hit gametocytes, and the antifolates and atovaquone proguanil at causal liver stage activity. I'd encourage you to pause the video and try to reproduce this table from memory. Now let me translate all that mechanism into practice. For uncomplicated malaria, I'd reach for a 3-day oral ACT. Add single low-dose primaquine for falciparum to block transmission and give a radical cure for Vivax or Oval. For severe malaria, my approach is 4-artesunate for at least 24 hours, then a full oral ACT course, and parenteral quinine only if artesunate isn't available. For chemoprophylaxis, I choose atylchromproguanyl, doxycycline, or mefloquine based on destination resistance, started before travel and continued after. Let me spend a moment on the recurring threat in this whole story, which is resistance. Chloroquine fell to PFROT mutations. SP resistance emerged within just a few years through DAFRU-DIPS mutations, and now partial artemisinin resistance, driven by Lecture-13, is spreading from Southeast Asia into Africa. Look with me at this bar comparison because it makes the core point. A resistant parasite is far more likely to survive monotherapy than combination therapy. That's exactly why we combine our drugs and steward them carefully. Let me wrap up by giving you 5 anchors to hold on to. First, target the stage. Second, know the mechanism. Third, combine rather than go solo. Fourth, remember the unique radical cure role of the 8 aminoquinolines with G6PD screening. And fifth, respect resistance. My promise to you is that once you master drug to stage plus mechanism, you can reason through almost any antimalarial question rather than memorizing lists. Stick around. I put 2 self-test quizzes right after this. Let me use this as an active recall checkpoint after our mechanism section. I want you to cover the right column and answer each prompt aloud before you reveal it. Let me reinforce the 4 menistic buckets with your heme detoxification blockade for the 4 aminoquinolines, free radical generation for the artemisinins, folate pathway inhibition through DHFRD, DHPS for the antifolates, and mitochondrial cytochrome BC1 disruption for atovaquone. And don't forget that primaquine is the outlier that reaches the liver hypnozoites and gametocytes. Now let me run a quiz to bridge mechanism to bedside decisions. I want you to remember that ACT is first line for uncomplicated falciparum, that 4-artesunate is the drug of choice for severe malaria, and that G6PD screening is mandatory before any 8 aminoquinoline. Let me use the PADRA question to revisit with you why combination therapy both improves cure rates and protects against resistance, and the prophylaxis question to highlight the liver stage, causal agents like atovaquone proguanil. Let me close with this final quiz to consolidate our resistance and prevention material. I want to walk you through the molecular markers. You absolutely must know PFROT for chloroquine, Dapis for sulfadoxine pyrimethamine, and Lecture-13 for the partial artemisinin resistance now spreading from Southeast Asia into Africa. Remember with me that combination therapy raises the genetic bar against resistance. And in prophylaxis, I want you to clearly distinguish the causal liver stage agents from the suppressive blood stage ones. That brings us to the end of this lecture. Thank you so much for watching. If it helped you, please give it a like and subscribe to the channel, and be sure to check out my other videos for more pharmacology walkthroughs like this one. I'll see you in the next video.